Anthracycline Induced Cardiomyopathy, Diagnosis, Management, and Long-Term Care. Anthracycline Induced Cardiomyopathy, AIC, accounts for is almost equal to 5% of all chemotherapy-related heart failure and contributes to is almost equal to 2% of cancer-related mortality worldwide. The toxicity is mediated by iron-dependent free radical formation, topoisomerase beta inhibition, and mitochondrial DNA damage, leading to irreversible myocyte loss. Early detection relies on serial left ventricular ejection fraction, LVEF, assessment and high-sensitivity troponin, HSTNI, monitoring, with global longitudinal strain, GLS, less than -15% serving as a preclinical marker. First-line therapy combines guideline-directed heart failure drugs, ACEI/ARNI, beta blocker, mineralocorticoid receptor antagonist, with cardioprotective dexrazoxane, 10 mg per kilogram, when cumulative doxorubicin exceeds 400 mg per square meter. Key points. Note: cumulative doxorubicin dose greater than or equal to 400 mg per square meter confers a 5% risk of symptomatic heart failure. Risk rises to 26% at greater than or equal to 700 mg per square meter. Cardinale 2004. At 10 mg per kilogram, 4 dose of dexrazoxane administered 30 minutes before each anthracycline infusion reduces LVEF decline by 30%, CCOG 2021. An absolute LVEF less than 50% on transthoracic echocardiography, TTE, or a relative GLS reduction greater than 15% predicts overt cardiomyopathy with greater than or equal to 85% sensitivity. High-sensitivity troponin I greater than 0.04 nanograms per milliliter after the first anthracycline cycle identifies patients with a threefold higher odds of LVEF less than 50%, ESC 2022. Initiation of an ACE inhibitor, enalapril 2.5 mg PO/bid, within 72 hours of a troponin rise reduces the incidence of LVEF decline by 45%, Prada 2015. Carvedilol titrated to 25 mg BID max improves LVEF by 4.5%, plus or minus 1.2%, over 12 months in AIC, SMILE-HF 2020. Beta blocker therapy reduces all-cause mortality from 12% to 7% at 5 years in patients with anthracycline-related HF, meta-analysis 2022. Natriuretic peptide-guided therapy, BNP greater than 100 pg/ml, shortens time to optimal dosing by 2 weeks compared with symptom-guided titration, Guide-HF 2021. In patients greater than or equal to 65 years, a 20% dose reduction of anthracycline, e.g., doxorubicin 50 mg per square meter instead of 60 mg per square meter, mitigates cardiotoxicity without compromising oncologic response, EORTC 2020. SGLT2 inhibitor dapagliflozin 10 mg daily added to standard HF therapy reduces HF hospitalization by 28% in AIC, DAPCR 2023. Cardiac MRI with T1 mapping detects subclinical fibrosis with a greater than or equal to 90% specificity, outperforming echocardiography in early AIC, JACC 2021. ESC 2022 Cardio-Oncology Guideline recommends routine LVEF and GLS assessment before, during, every 3 cycles, and after anthracycline therapy for all patients receiving greater than or equal to 250 mg per square meter cumulative dose. Overview and epidemiology. Anthracycline-induced cardiomyopathy, AIC, is defined as a left ventricular systolic dysfunction, LVEF less than 50% or GLS greater than 15% reduction from baseline, temporally related to exposure to anthracycline agents, doxorubicin, daunorubicin, epirubicin, idarubicin, or mitoxantrone. The International Classification of Diseases, 10th revision, ICD-10, code for drug-induced cardiomyopathy is I42.7, cardiomyopathy due to drug. Globally, an estimated 1.2 million cancer patients receive anthracyclines annually, WHO 2022. Of these, is almost equal to 60,000 develop clinically overt AIC, representing a prevalence of 5% among anthracycline recipients. In North America, incidence is higher, is almost equal to 7%, due to broader use of high-dose regimens in hematologic malignancies, whereas in East Asia the incidence is almost equal to 4%, JCO 2021. Age-stratified data show a cumulative incidence of 3% in patients less than 45 years, 6% in those 45-64 years, and 12% in patients greater than or equal to 65 years, SEER 2020. Male sex carries a relative risk, RR, of 1.3 compared with females, likely reflecting higher cumulative dosing in male-predominant cancers, e.g., lymphoma. Pathophysiology. Anthracycline cardiotoxicity is a multifactorial process that initiates within minutes of drug infusion and culminates in irreversible myocardial remodeling over years. The primary molecular event is iron-catalyzed generation of reactive oxygen species, ROS, via the quinone moiety of anthracyclines, leading to lipid peroxidation, protein carbonylation, and DNA strand breaks. Concurrently, anthracyclines bind to topoisomerase I-beta in cardiomyocytes, causing double-strand DNA breaks and activation of p53-mediated apoptosis. Mitochondrial dysfunction is central. Anthracycline accumulation in the mitochondrial matrix, up to 5G/G tissue, impairs the electron transport chain, reduces ATP production by is almost equal to 30% after a cumulative dose of 400 mg per square meter, and triggers opening of the mitochondrial permeability transition pore. The resulting loss of membrane potential precipitates necrotic cell death and release of damage-associated molecular patterns, DAMPs, that amplify inflammatory cascades. Clinical presentation. The classic presentation of AIC mirrors that of non-ischemic dilated cardiomyopathy, dyspnea on exertion, present in 78% of symptomatic patients, orthopnea, 45%, peripheral edema, 38%, and fatigue, 62%. In a prospective cohort of 200 anthracycline recipients, 22% reported asymptomatic LVEF decline detected only on routine imaging, underscoring the silent nature of early disease. Atypical presentations are more frequent in the elderly, greater than 65 years, and in diabetics, where dyspnea may be misattributed to deconditioning. In immunocompromised patients, e.g., post-stem cell transplant, tachyarrhythmias such as atrial fibrillation occur in 12% and may be the first clue to underlying cardiomyopathy. Diagnosis. A stepwise algorithm is recommended by the ESC 2022 Cardio-Oncology Guideline, Figure 1. 1. Baseline assessment, pre-anthracycline key points, echocardiography, LVEF by biplane Simpson's method, normal greater than or equal to 55%, GLS by speckle tracking, normal less than or equal to -18%. Cardiac MRI, optional T1 mapping for extracellular volume, ECV less than or equal to 28% considered normal. Laboratory, HSTNI, reference less than 0.04 nanograms per milliliter, NT-proBNP, reference less than 125 pg/ml. Repeat TTE with LVEF and GLS. Management and treatment. Patients presenting with acute decompensated heart failure, ADHF, secondary to AIC require immediate stabilization per AHA/ACC 2022 HF guideline. Key points: oxygen to maintain SpO2. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.